Hello, and welcome to the Innovation Forum AI podcast, a space where we explore how artificial intelligence is transforming public health. Welcome, everybody. My name is Oliver Morgan, and today we're joined by Sam Scarpino, one of the leading researchers in AI for public health in the United States. Sam is Professor of Public Health and Health Sciences at Northeastern University and Director of AI and Life Sciences at the Institute for Experiential AI. So Sam, welcome to the podcast.
Thanks for having me, Oliver.
It's really great. We've interacted quite a lot over the last couple of years. Maybe you could just start by giving a bit of a background to what you do at your institute and maybe a few of the kind of milestones which led you to become the director of this institute.
Yeah, at the Institute for Experiential AI, we're focused on this word experiential, and it means three things to us. So the first thing is that we used to say training the next generation of decision maker, and now we just say training decision makers to incorporate AI effectively into their decision process. So basically across all sectors, public health and global health being no different, decision makers are being given the output of AI models and being asked to incorporate those into the decisions that they're making. And so these are people that may not be running AI models, but they need to be able to make smart decisions, understand how to put that in the context of their existing decision processes. The second is the importance of humans in the loop. And this is obviously critical from the perspective of ethical and responsible AI, but it also turns out that these AI tools that we're using, they function best when used by experts. And so we want to actually build them by design with humans in the loop. And the third piece is partnering with organizations like the WHO, but also state, local, regional health organizations across the globe to help them design and implement AI tools for their own workflow.
That's a great start to give an overview of your institute. You know, I think we're all caught up in the excitement of AI and things are developing so quickly. But one of the areas that I think has been a little bit overlooked, and certainly in the public health space, is what needs to be in place. What is the kind of infrastructure or the foundations that we need to use the AI for public health? I mean, what are your thoughts on that? You and I have discussed that a little bit in the past.
Yeah, and that actually is the answer to the other half of the question you asked about sort of how I found myself in this position at Northeastern University. I've been working for effectively my whole career on how we design and implement public health surveillance systems. And really that starts and ends with the question that you want to ask and then the kinds of data that you need to best ask and answer that question. And whether that's developing new algorithms for picking surveillance sites that you might enroll in a surveillance system, how you bring in new kinds of data like digital trace and internet data, now wastewater surveillance, and then the technology layer that sits in between the primary data collection and the decision support algorithms and dashboards. And so that, for me, has been a part of this process and central to the work that I've been doing all along. And turns out that's exactly the same thing that you need for good AI. It's all about the data. And I found myself at the Rockefeller Foundation, where I was working on the health team to develop surveillance tools, decision support capabilities, help bring new data networks to life, and heard this opportunity at Northeastern to work on this both in the pandemic space, but also much more broadly outside of the pandemic space in the health and life sciences. And I used to joke, I started, I think 3 months before, actually not 3 months, about 3 weeks before the ChatGPT release. And everyone asks sort of like, how did you know it was going to happen? And of course, the answer is I didn't know it was going to happen. But I think a lot of us have felt like the AI capabilities were increasing, and that the opportunity to take some of these, especially generative AI technologies, more seriously was right upon us.
Great. Well, I mean, how should we go about thinking about this, Sam, and from a public health perspective in terms of getting our data systems together? I mean, as you said, this is not something that's only relevant because of AI, but let's say it's even more relevant now because of AI, because we can't maximize the opportunities of AI if we don't have data systems in place. But what are we looking at? Are we looking at a complete rebuild of public health data systems? Are we talking about minor shifts? You know, what's your take on it?
Yeah, a couple answers. So the first is post 2009 pandemic, H1N1 pandemic. We were working with a lot of organizations, primarily in the United States, to think about how you design optimal disease surveillance systems in terms of the data coming into them. And the first step in that process is defining very clearly your public health and global health objectives. So in terms of thinking about what kinds of data systems do we need, how do we approach digital transformation in the context of AI, the first thing that you want to start with is, what do we actually care about from the perspective of global health or public health? And it needs to be defined in such a way that you can actually benchmark whether or not these systems are providing improvements or not. And so maybe in the context of influenza, we might say, well, we care about influenza in underserved populations. You need to be more specific than that. Where are these underserved populations? What do we mean by underserved? Are we in a country where you have universal health coverage or not? What does the access look like to different healthcare facilities? And so the more specific you can be about what it is that you're trying to impact, the more likely it is that you're going to build the right data system in the first place. And this actually isn't unique to global health or public health. When we work with a pharmaceutical company, we might talk to them about very clearly defining the KPI that you're going to measure as a part of your business value that you have. So the first part is asking, it doesn't matter whether it's the right or wrong question, it's asking the question in the right way. The second component then is to think about what sort of technology systems you need to have in place. There's a book called The Data Revolution by an author named Kitchen, and they have in the book 5 levels, but I condense them down to 4 levels, in part because I can never remember all 5 levels. But the 4 levels are basically like, are your data trapped in pen, paper, Excel? That's kind of level 1. The second level is, are they trapped in proprietary software that's going to make it very hard for the data to be used for lots of public health measures? The third is, are they in open source formats, but do they miss the metadata that's tied to how they were collected? And the final piece, which is really the one you need for AI and the one that we need to march towards, is open access, open source data. It doesn't mean you have to share it with everybody, but it means that it has to be interoperable for lots of different software programs downstream, and then tied to the metadata that tells you how the data were collected in the first place. So those two things, asking the question, the right question in the right way, and pairing that with the kind of digital data that's interoperable and fit for purpose tied to metadata, that's what we have to do. And of course, those things require effort and coordination, multi-sector, and also technology.
I mean, I think that's a great starting point for thinking about our data systems going forwards. But it does, I guess, surface an additional challenge, which is that, we now have the capability of combining data from so many different sources in many different ways, which means that on the one hand, we can answer more questions and get, I guess, to the heart of a whole set of different problems. But then I guess we're faced with a bit more of a technical challenge of being able to put all those different types of data together. I mean, how do we go about managing that in the current data environment or data landscape?
Well, first, I started by saying that there's really not a lot that's new. One of the things that also isn't new is that it's hard to get people to pay for digital transformations and data systems. This has been a persistent issue in global health and public health for at least the last 10 years, but probably as far back as you could possibly go when people were collecting data on health challenges. There's never been enough investment in those data systems. So the first is, we're faced with the same persistent problem that we have not yet come up with a great solution for that works in all settings. The second, and maybe more practical answer, is going back to this idea about asking the question that you care about in the most specific way. And so, if I'm faced with 100 or 200 different data sets or signals, and I somehow need to integrate them all together, one of the ways that I might do that is by filtering out some of the ones that are just mostly going to be noise. It doesn't mean they're actually noisy. It's just noise with respect to the signal I'm looking for. And then combine the rest of them in some kind of smart way using an algorithm that someone comes up with. But in order to figure out how you do that, you need to know exactly what it is that you want these systems to be telling you. And so again, I think the more time that we can sit around and think about the right questions to ask, the more likely it is we're going to be able to do a good job on the actual data integration piece. But that's also part of the trust building exercise that I think feeds back onto the challenge of investing in these data systems and building the kind of multi-sector collaboration. So going back, I would say the more we focus on the right question asked in a specific, measurable way, the better we're going to be at integrating these various pieces of data.
Well, I guess it's encouraging to know that the first principles still stand, and a lot of what we've been working on in public health is still, I guess, necessary and important. But then I guess we also have to think about, how the outputs of these analytics are also going to be used. And I know a little bit about some of the work that you've been doing within the Epistorm project, but maybe you can talk a bit about that and how you are thinking about connecting these kind of data platforms and data systems to decision makers, and what are the challenges with doing that?
Yeah, that's the other big issue, right? As you think about the proliferation of dashboards that have happened over the past 10 or 15 years, there's a dashboard for everything now. There's probably a dashboard for the dashboards. And it's not entirely clear how those have actually been translated into improved health and well-being of our populations. And again, part of the challenge with building data sets is there is often this gap between the individuals collecting and curating the data and then the decisions that are being made on top of the data, and there's not a clear link between the two. And so what we're trying to do at this center called Epistorm, which is funded as a part of the US CDC Center for Forecasting and Outbreak Analytics InsightNet, is to develop innovative new tools that are embedded inside of healthcare delivery organizations that actually deliver meaningful value to those organizations in terms of the decisions they need to make in terms of the health and well-being of their population. So one example of this would be in the United States, as in many countries, we make very complicated and expensive staffing decisions at the hospital level. You've probably heard many, many times throughout the pandemic about so-called, non-essential surgeries being canceled because of COVID. And these non-essential surgeries are often people with cancer that need to have a surgery. It just means that it could happen in a month, not in an hour. And they often need the same beds, the same nurses, the same recovery services as somebody with a respiratory infection. And so they need to be able to make staffing decisions based on respiratory surges. Can we deploy tools down to the hospital level in order to improve their situational awareness? And what's exciting about this is that then the hospitals are also contributing data back into the broader state, regional, and international public health efforts because they see that value in terms of the two-way relationship. We're also focusing on rural areas, which again are more challenging to predict than urban areas. We've seen a real maturation in our ability to predict, especially respiratory infections globally, but there's still a pretty big gap between urban and rural forecastability of these different outbreaks. And so how do we bring these technologies into the rural areas where they're already understaffed? And so that's one of the things that we're really trying to do as a part of this Epistorm Center is bring these technologies to the point where you're actually making decisions about the local level public health impact that is what we know matters, right? Everyone always talks about how public health is always local, but we don't see that much effort to bring a lot of these technologies down to the local level. And that's one of the things we're focused on at the Epistorm Center.
And what are the opportunities that AI presents within all of this work? So, we've spoke a little bit in this podcast about the importance of the data foundations, which in essence haven't changed that much. The collaborations and working across different parts of the health system, again, are critically important. But you mentioned that, getting some of the analytics and some of the decision making, out from the central level down to the local level is critically important. Is there a role that AI in particular can play to help with that?
Yeah, so far I've managed to not actually say anything exciting about AI yet throughout the entire part of the podcast. It's just the same old boring, we don't know how to solve the data problem issue that we've all been dealing with throughout our careers. And in some ways, I also still don't have an exciting answer about AI. So the biggest thing for me that I think AI has actually opened up, it's one of the few net new capabilities that I think we're seeing with generative AI, is in this digital transformation. So all of us are sitting on stacks of pen, paper, Excel, digital stacks of PDFs. We might have databases, but they have different schemas or Microsoft Excel sheets. And it's very tedious and time consuming to move these data into different formats. With generative AI tools, you can massively streamline this process. And for us at Epistorm, but also at the Institute for Experiential AI, this kind of Gen AI guided digital transformation is the biggest way that we're bringing AI into the health space, because it allows you to very quickly move data sets into a unified framework for analytics, but also move data between different reporting formats. So different dashboards, different PDF-based situational reports, different websites, if you have APIs that are going to be serving up certain kinds of data. And that really serves two purposes. First, it creates new digital assets that tend to resonate with decision makers very quickly because they see things that they've never seen before, and they know how expensive this kind of stuff is. And the second, it really does save time and energy without replacing jobs. Saves time and energy for the people that, are trained epidemiologists and spend half the day entering and cleaning up data on the keyboard. Now they're spending the other half of the day actually using that to make better decisions for their organization. So the biggest way that we're bringing AI into this space is to actually help streamline that digital transformation process.
Yeah, I think that's a really important message, that AI can really be an unlock for the data that we already have, and be able to allow us to use that more efficiently and for gaining more insights. I mean, I think that's encouraging, because I guess at this point, we're not looking at necessarily having to use the most cutting edge types of AI for this work. There's kind of a lot of groundwork already laid for that. Is that right? I mean, is this, we can use things that are now pretty well tested?
Yes and no. There are a couple of really significant challenges, especially when we think about the global health context. So the first and the biggest is that most of these generative AI tools are built to function in English. And so as soon as you move outside of English, even into very common languages, Spanish, Chinese, you still have significant barriers, much less any language that we might call low resource. Even if 5 million people speak it, we might call it low resource language if you put your tech jargon hat on. So the first issue is around language. The second issue is that most of these Gen AI tools run in the cloud. They require specialized pieces of hardware or access to certain size hardware that you can really only use in the cloud. And that means that many countries that have GDPR type laws, if they don't have in-country data centers and in-country cloud GPU providers, you may not be able to run some of these algorithms because you'd be violating the health protection, privacy protection laws in the country. So there is a pretty significant gap that exists there. And the third piece is, we don't exactly know by how much, but we know that the venture capitalists and investors are heavily subsidizing the cost of these generative AI tools. We know that they have seems to be growing, but sort of at this stage, largely unquantified environmental impact. And so the more that we embrace some of these tools, the more that we might find ourselves locked into expensive vendors once the costs go up, or locked into sort of ever spiraling climate costs associated with powering these data centers, or water costs in many parts of the world where water is a scarce commodity. So I think there's a huge amount of opportunity in the global health space, a huge amount of challenge because of the language issues, because of the access issues, and because of both the monetary and climate cost issues.
Yeah, I mean, I think there's quite a lot of there's quite a mountain still to climb, but give us some optimism. I mean, are there some examples where we see some of these some AI in action to help actually use data that's already collected on routine health statistics, maybe that can speed things up and make things better already?
Yeah, two options. One is a little bit more advanced than the other, and it's also a little bit more local to me. So we work with an organization in the state of Maine, which, if you're not familiar with Maine, it's one of the most rural states in the U.S. It also has one of the older populations in the U.S. And most of the time, if an individual has a solid state tumor, that tumor is going to be sequenced. Most oncologists don't actually know how to take those sequences and translate them into treatment or translate them into enrollment in clinical trials. And so you have these molecular tumor boards where many different oncologists with expertise in genomic medicine will look over the sequence and make recommendations to the treating oncologist. We have one of these in the state of Maine. The problem is that a new patient or a new case shows up and it's going to have emails, multiple different faxed test reports, electronic health records, and all of those have to be integrated into a case report before the oncologist can look at it. And the only people that can do that are people with expertise in genomic medicine. So you have a lot of individuals that are sitting around doing manual data creation and then spending time trying to reference clinical trials and reference in new combination therapy. And so we've been working with this tumor board, which is out of the Jackson Lab, the Maine Cancer Genomics Initiative, to leverage these kinds of digital transformation tools to speed up the patient onboarding process. With the result being they can see more patients, they can spend more time on each case, and then ideally we can then actually scale this both throughout the United States, but also globally into areas which is all over the world where you have a shortage of oncologists that are trained in genomic medicine. So that's the first. That's been running for a couple of years. It's fairly well advanced. The second is actually quite new. It's a project that just kicked off with the Gates Foundation, with an organization called CHAMPS, groups like ICZ-DRB that you probably heard of. And this is to try and improve cause of death determination. And for those of you that are maybe less familiar with this, what you're probably familiar with is that a lot of our baseline numbers in the global health space are determined by mortality surveys. We measure how well different interventions are performing against the mortality records because they're often seen as the gold standard. Very few autopsies happen globally anymore. There's been an increase in these minimally invasive tissue samples, or MITs, to improve autopsy reports, but we still overwhelmingly rely on case notes, interview with family members, so-called verbal autopsies. So how can we bring these digital transformation and data interoperability tools into the space of cause of death determination? This is going to be a global effort to leverage the kinds of not just generative AI tools, but new kinds of ontologies and knowledge graphs. This is work that Professor Ben Giori out of Northeastern University is leading, to bring these tools into the space of global health in a really high impact area that has far-reaching consequences. So this is just getting started, but it's an area where I expect we're going to have a lot of impact very, very quickly.
I mean, that sounds super interesting. I mean, what are the knowledge graphs actually doing? I mean, are they being used to, help look through all of the different data and, make connection between different signals in essence that are in those data, or how are you using those knowledge graphs?
Two interesting things, well, many interesting things are happening with knowledge graphs. I think a lot of people are really excited about using knowledge graphs together with generative AI, because generative AI tools, the math in them is why they hallucinate. They hallucinate maybe not by design, but the math is designed in such a way that they're going to hallucinate. One of the things that we can use with knowledge graphs is actually correct some of those hallucinations, right? Because you see patterns, you want to understand how common those patterns are. And one way to do that is to look retrospectively at the data you've seen and find out how often you have the co-occurrence of different kinds of terms that show up together in the knowledge graph and also in the generated text. So a lot of enthusiasm around knowledge graphs in the context of generative AI. Specifically in this case, there's two things that are really important. The first is you have a lot of audio transcription. And that audio transcription, there's a generative AI tool, a neural network often, may not be generative, but a neural network that's doing the audio to text transcription. If it makes a mistake in medical language, it's not going to spell acetaminophen like with an M and an H in the wrong place. It's going to come up with, it's like acid muffin or something, right? It's going to make up a word that sounds a little bit like acetaminophen, but is not that at all. And so you could think about using knowledge graphs to actually do a different kind of spell check, which is to say, okay, we see the word headache, we see the word knee pain, we see a bunch of words that are associated with pain that would typically go with some kind of pain reliever. And instead, we're seeing this word acid muffin in there. And we would then maybe guess that it actually should be acetaminophen, because you could then think about what is the actual pronunciation of these various words. So the first is a kind of medical spell checker. The second is we've got things like ICD-9, ICD-10, ICD-11 is coming. You have WHO standards around verbal autopsies. You have all kinds of ways of describing a condition that an individual had or a cause of death. And you want to understand how they're actually all related to each other. That way, if you're reporting to the WHO or to a Ministry of Health or to a hospital or to an insurance company, you can report in the right language, or you can ingest in one language and translate it into another language. And so we use these knowledge graphs as basically an interoperability layer. It's something that people are calling now a data fabric, an interoperability layer between all these different ontologies that describe a condition that an individual may have.
Well, that's really promising. Sam, you've mentioned knowledge graphs a couple of times. Maybe you could just explain what a knowledge graph is for listeners who might not be familiar.
Yeah, knowledge graph, it sounds a lot fancier than it is, although it's very useful. So I don't want to downplay its fanciness. But maybe the easiest way to think about it is, imagine I have a whole bunch of outbreak alerts, right? So the WHO provides regular outbreak alerts on anything that bubbles up as potentially important to its member states or regionally, internationally. And what I want to do is understand something about how often we're seeing things like plague infections in different parts of the world associated with different types of rodent exposure. And one way that I might do this is I could take all my outbreak alerts and I could do a search for plague, and then I could do a subset search for different kinds of rodents, although there are a lot of different kinds of rodents, and then I could cross-reference the different countries, and that would take a lot of work. Instead, what we could do is use natural language processing to perform what's called named entity recognition, which is just you have a dictionary basically of names that you map. And so all the rodents, I know that they're all rodents. There's a node that says rodent. And then down here, we have all different kinds of rodents that might be attached to that. And then we might have, bacterial infection. And then we might have the genus that the plague bacteria is in. And then we might actually have the species of the plague bacteria. And you build up this hierarchical relationship between all these various terms. The same is going to happen on the geographic side of things. We have all the country names. We have the country name in the languages that are spoken in that country, as well as in English and in French, maybe in many other languages. And so then what we can do is look in this knowledge graph and look at the connectivity patterns between how often we see a particular rodent name associated with a particular country, associated with particular plague bacteria. Now, there are some details, like you have to decide over how much text. Is it a single report? Does it have to be in the same sentence? Does it have to be on the same week or month? So there are some nuances, but that's the idea behind a knowledge graph, is that it represents the relationship between entities as they co-occur in text or in reference databases or in ontologies. And those are used to identify that relational structure between them in many ways similar to how you might operate with a relational database. And again, they're incredibly powerful because it allows for interoperability. It allows for disambiguation of terms. So think about all the various ways in which we might describe a geolocation. And in some ways now it's helping us think about how we better ground the AI tools that we're using in the realities that we're seeing in the text that we've collected historically.
There seem to be more and more ways that we can use technology that's kind of coming off the production line into, really, let's say, unlocking the potential in a lot of public health data. I mean, I guess in the near term, we're going to live or continue to live with a bunch of biases and other kind of issues that are inherent in the data, which then kind of feed through into the analytics. I mean, what do you think we can do with some of those issues in the near term?
Well, one of the things that AI has not proven itself very good at doing is ameliorating bias. If anything, we tend to see that it exacerbates it. And the reason is not often because anyone has any ill will, but because these algorithms, they're not entirely black box in the sense that we often have a very good understanding of how the math works. They're often black box in the sense that we don't really know how to predict the output from the input. So you think about like a regression model, you can stare at it and you can explain why it is that you put in this number and another number comes out the other side. For neural networks, it's much more difficult, often impossible, to explain why it is that you put one thing in and another thing comes out. Again, they're not black box in the sense that we don't know what the math is and what it's doing. We just don't have that exact mapping explanation. And that lack of mapping can unintentionally exacerbate biases that are present in our data sets. And so the thing that's most important is to be as critical as possible around developing tests for what kinds of biases may be present in a particular model that we're using. And this is where the subject matter expertise is really critical. I published a paper in 2020 looking at influenza forecasts by socioeconomic status. And one of the things that you see in the US is that individuals in the lowest income quartile, they have the highest per capita rates of influenza hospitalization. Now, part of the reason that they have the highest per capita rates of influenza hospitalization is that in the US, they have less access to primary health care. So by the time they find themselves looking for medical care, they're already way past the point where someone in the upper 3/4 of the income distribution would have received treatment. Now, what does that mean? That also means that they're not being captured in many of the data systems that we rely on for flu forecasting. They haven't gone to the primary healthcare provider. They may not have Googled for symptoms. They also don't go to the emergency department, which is a persistent myth associated with individuals in lower income quartiles in the US. And so what we showed is that if you build machine learning algorithms on top of traditional influenza surveillance data, there's a significant performance gap in that lowest income quartile, which also has the highest need. Now, anyone that works on flu in the United States would tell you right away that this kind of data bias is going to be present. We didn't necessarily need to run a whole study to show that this was here. That's why pairing individuals up together, folks that are thinking more about the algorithms and the data systems, with the folks that have the lived experience, the epidemiological and global health experience for these pathogens for the communities. Again, nothing new, the same kind of co-creation that we always talk about when we think about new sorts of technology in global health is critically important from the bias perspective, because the less thought goes in from the beginning, the less subject matter expertise, the more likely it is that you're going to end up in an unanticipated way amplifying bias in a method that could and likely will create a lot of harm, or introduce more structural mechanisms in which those biases are just perpetuated or exacerbated.
Yeah, and I guess in the worst case scenario, some of those biases might end up in the embeddings for some of the large language models, which then, as you say, kind of perpetuates and kind of hard codes these biases into the models that people are using. And I think actually the bias issue is probably one of the hardest ones to understand. And as you mentioned, you really need subject matter experts who really understand the topics to really figure out what those biases are and be able to address them, I guess, at the data generation stage, but also at the data curation step and at the analytics level as well. I mean, moving, I guess, incrementally one step forward into, we've spoken about the data foundations, we've spoken about maybe some of the use of AI and models to help with that, and then, create more robust data sets. How can we think about AI when it comes to data analytics for public health?
There's an interesting thing about the word bias. So it has a negative connotation. Often it's negative. It also means different things to a statistician than to a public health worker. Sometimes the public health workers are also the statisticians, but sometimes they're separate people. It also sometimes is real. Now, what do I mean by this? One of the things we were working on at the Rockefeller Foundation and that has really caught on globally is early estimates of the growth rate of different variants. They tend to be biased high. If you go back and look at the messaging that was coming out, SARS-CoV-2 variants, I'm sure the same is also true for, we probably start calling them flu variants and everything's going to be a variant now. But the SARS-CoV-2 variants, a new one would come up, and almost invariably we would be off by a factor of 2 in terms of its estimated growth rate. So what we did is we developed a bias remediation algorithm that basically just shrinks the estimate by what we historically have seen the bias be. And this works, except it's probably biologically real that the growth rate was high. It's actually probably not an algorithmic challenge. If you think about what has to happen for a variant to go from super rare to common, even if it has an advantage in terms of immunological escape, it still has to overcome the disadvantage of being rare, just stochastic effects. It goes extinct on its own, never takes off. So you might expect that if a variant is going to grow, there will be a short period of time where it has unusually high growth rates. Maybe the couple super spreader events that were just bad luck for the population, good luck for the variant. And so one of the things that often happens is we develop algorithms to remediate the bias, but that's actually a real biological feature that may be quite important for thinking about in the context of an intervention. And so then, thinking about data bias in terms of collecting information on populations, we know that one of the ways that populations are disempowered is by not being included in data sets. And we often know that another way that individuals and populations are disempowered is by including them in data sets in a way that allows for new and more invasive kinds of surveillance. And so we're constantly going to be balancing between these two different reasons, which is bias in the data set for things that we might want to ameliorate, and bias in the data set for things that we might not want to ameliorate, that we may need to understand much more robustly from a sociobiological perspective. So I think as we go into this space of developing new AI algorithms, we need to think very carefully about what is the kind of bias that we're trying to address and what are the underlying root causes of those biases. Because if we have this amazing black box debiasing algorithm that in many cases might actually make things less equitable on the other side as a result of those debiasing algorithms, or it may give us the wrong information about a particular variant with respect to its threat profile. And again, so going back to what we started with at the very beginning is thinking very carefully about the question and the impact that you want to have, and then assessing what are the structural and root causes of the biases that may be creeping in, then pick the right AI algorithm off the shelf to do your best to try to bring in new data through digital transformation, ameliorate biases in a way that we think will lead to more, equitable solutions and outcomes.
I mean, there's a lot of talk, certainly in the public health space, and I presume in many other scientific disciplines, about at the analytics step that, let's say, traditional statistical approaches are in many ways more efficient, at least computationally more efficient than trying to use AI tools, at least at the moment. Presumably, that's something that you guys have experienced, that, whether AI is outperforming traditional statistical approaches in the analytics step. And do you see this as a game over for AI in the analytics, or do you think there's still some competition there?
Yeah, a couple thoughts on that. So the first is, certainly a year ago, neural networks were consistently outperformed on tabular data, which is basically all the data we work on in the public health space. So take your favorite random forest model or logistic regression or some other regularized regression that maybe is a little bit fancier than logistic regression. And that's almost always going to be outperforming the neural network on your tabular data. There have been new neural network architectures specifically focused on improving performance on tabular data. A lot of these are kind of offshoots of these graph neural networks that you may have heard of. And those have significantly closed the gap between, in particular, random forest models and neural networks on tabular data. I expect sometime soon, probably already largely happened, that we will eclipse the performance of these statistical or machine learning models on tabular data. Now, the other part of it is the amount of data required to train some of these models. So that's only getting worse from the perspective of how much is necessary to build one of these neural network models and use it against your data. One of the things that I believe is true, and this is an active area of research for us at the Institute for Experiential AI, is that most of the living systems that we care about, of which public health is one of them, they only produce small data. Now, what do I mean by that? Well, the data are highly context dependent. They have lots of interdependencies. They're generated from a complex adaptive system, which is the socio-technical system that we live in. And so there is no more data to go out and collect, or there are no more data to go out and collect, depending on what your preference is. And that means that we can't just keep increasing the data set size, because then what you're doing is you're mixing different signals. Maybe it's changing over time as demographic patterns are changing, urbanization rates, the climate is changing, different pathogens are coming in, we have different variants, we have different vaccine strains, we have this K variant for influenza that showed up. And so you're actually degrading model performance by mixing these different signals together in an effort to bring larger data sets to the problem. Instead, we think that we need to build algorithms that work on the data sets that we collect, that we think represent essentially the totality of the data. Another thing that I often point to is the question comes up, is it better to have a 1% random sample of the population or a very large sample of the population? Maybe it's a 75%, 80% sample of the population, but it's biased with respect to your signal by 1%. And the answer is always the smaller sample that's collected randomly, because it's much harder to figure out how you debias a sample that wasn't collected appropriately than it is to analyze a data set that was collected in a fit for purpose way. And so I think one of the things that we're going to see is increasing drive towards these small models that operate on the types of data sets that are being collected, and not because we don't have enough money to collect more data. It's because there is no more data to collect coming from that signal that we're interested in studying.
Yeah, I mean, there's a lot of talk in the AI space in general about the performance gains starting to level off, in part because, as you've said, they're getting to the point where they've ingested all the data that's easily available, good data and good quality data and bad quality data. So, and a lot of commentators saying that really, it's the quality of the data now is the main game in terms of improvements for AI. But in terms of the analytics, in terms of forecasting, in terms of understanding the world around us and thinking about, some short and near-term predictions, are we making progress in that space? Are we better today than we were a few years ago? Is this going to continue to improve? Or are we also leveling off in this domain as well?
I think we're still making huge progress in the forecasting and outbreak analytics space. It was actually one of the things that occurred to me during this influenza K variant is probably a month ago, actually more, maybe 2 months ago, we had estimates coming from the UK HSA and the US CDC looking at the growth advantage of this K variant over other H3N2 and H1N1 variants that were circulating. And for the flu people, I apologize that I keep calling them variants. I know that that's probably making, it's like nails on a chalkboard, but I'm going to keep doing it. 5 years ago, that would not have happened. We certainly would not have had dashboards, and they would not have been accurate. They now were basically spot on and publicly available right at the very earliest stages of the outbreak. That's a huge accomplishment, both in terms of the analytic capabilities, but also their proliferation and uptake across the global health space. It's really hard to overstate how much science has happened in terms of the progress and how much advancement has happened inside of global health, public health agencies in terms of capabilities. We're seeing that regularly occurring year after year globally in different agencies. And some of this is because of new data sets coming online, like wastewater surveillance, new mobility data sets that are being made available, other kinds of high resolution, genomic, environmental case data that are being collected. So one piece is definitely the data side that's being improved. But the second piece is on the algorithm side, where we continue to see newer and newer approaches that allow us to ask and answer different kinds of questions. A specific AI example would be a lot of groups running agent-based simulations. Agent-based simulations are great for a lot of reasons, but they often don't allow you to generate the kind of uncertainty bands that are necessary for public health decision-making. We're seeing AI being used to extract low-rank versions of these agent-based simulations that you can run very, very quickly on the computer to generate those uncertainty bands. And this is the kind of thing that we're seeing kind of really transform the decision capabilities of public health agencies. So I don't think we've come anywhere near hitting the inflection point. Interestingly, there's a bunch of foundation models for time series forecasting. And the last I looked very carefully at them, which was 4 or 5 months ago, maybe 5% of the time series in there were from infectious diseases, and all of those were COVID hospitalizations. So from a basic development of foundation models perspective, there's not been a lot of work done on the epi side. And it's not because there's a shortage of data. We actually have a lot of epidemiological data that could be used to train these models. So I'm pretty excited and optimistic about what's ahead of us.
Yeah, it's interesting you mentioned that. We spoke to Gautam Prasad from Google Research not long ago, and Google Research has done a lot of work on time series. But as you say, not only in the health domain, in all sorts of other time series domains. And so I think that's definitely an area where more work can be done, and more public health data that's already out there could be used to feed into building some of these better time series models. Maybe we can kind of come full circle as we kind of come up to the end of the episode, and kind of think about how to translate a lot of what we've been talking about into the day-to-day work in public health institutions around the world. And I know that one of the initiatives that you and I have interacted with a lot is Global.health, which is an initiative that's very much looking at that translational component. Maybe you could talk a little bit about the Global.health initiative, and more generally, how do we get a lot of this exciting work into the day-to-day practice of public health departments around the world?
Yeah, Global.health is an organization that was founded in 2020 in the earliest days of the pandemic. It was founded by Moritz Kramer at University of Oxford, John Brownstein at Boston Children's Hospital and Harvard, and then I was at Northeastern University. And it's expanded now to essentially every continent, brought on individuals like yourself to be a part of the work that we're doing. And it was trying to solve a very specific and recurring problem, which is often during an emerging infectious disease outbreak or an emergency response to an established infectious disease, our data systems break. And we think there's a tight causal relationship there, because we use these data systems to prevent a small number of cases from growing into a large number of cases. And so pretty good chance, if something is growing very, very rapidly, we don't have the right data system in place to handle it. Now, there are going to be some exceptions, like if there was a 1918 style flu that would just move way too fast for any data system to collect. But like many other individuals, we were in front of an Excel spreadsheet entering data coming out of China via social media posts from hospitals. And we thought, well, there has to be a better way to do this. What we need is a data system that can rapidly evolve in response to a new outbreak. And so we developed this cloud-based data platform that assumes that data are going to be coming in from many formal and semi-formal sources, especially during kind of the first 100 days of a new outbreak response. And that our understanding of the data, the metadata, the different fields is going to evolve very, very rapidly. You think about how many times I've said the word variant so far on the podcast. That word variant didn't exist for all practical purposes in 2020. And all of a sudden we started calling them variants, and then we came up with names for them. And then there were 3 different ways of naming them. And then the WHO would name some of them in a special way. And then there were 3, other groups naming them in other ways. And then people on the internet using, Greek monster names to name the variants. And somehow all this stuff has to be mapped and interoperable. How many different names do we have for SARS-CoV-2, right? Was nCoV-19, and then there was some of it was 20 and some of it was 19, and some people capitalized the N, and it took a while for us to even just get the name down that we were going to call this thing. So we've since worked through funding from organizations like the Wellcome Trust, the Rockefeller Foundation, Google.org, to build this open source cloud data platform and also emergency response capability to support organizations during that first 100 days of emergency response. So you might think about Ebola or Lassa fever or Mpox or the H5N1 in dairy cows in the United States. Where we're going now is to bring federated learning into the Global.health platform. Federated learning is a technology that I think is going to play a key role in global health going forward. So what this allows you to do is deploy models and run them locally against data sets, and then bring back pre-specified results into either a central repository or into a regional repository, but you don't have to move the data around. And this is really important for a couple reasons. One, it's generally best practice not to copy data sets, just leave them where they are and run the analytics against the data and move the results back. But there are also plenty of countries ever growing that have laws that require certain pieces of health data to sit on their soil and cannot be moved. We also know within a country, there are major challenges, just one organization getting access to a data set that another organization has. And a lot of this can be alleviated through these federated learning platform. So I think that there's a really big opportunity to bring these kinds of cloud-enabled, open, rapid response data platforms that build the kind of AI-ready data that we're talking about as a part of their normal operating procedure into public health agencies. If for no other reason, then there's a huge amount of investment enthusiasm in AI, and you don't get good AI without good data. And so maybe one of the ways that we finally address this persistent challenge associated with good, high-quality, interoperable data sets, build trust, build data sharing networks, is around this dream and vision of the promise that AI holds. And so that's what we've been working on at Global.health. And we're, again, fortunate to have a lot of partners from local health agencies through universities, technology companies, multilateral groups, in order to try to build the kind of trusted open source software that actually works for the response and isn't just sort of built in a vacuum.
Well, thanks so much, Sam. I think we've covered a huge amount in this short conversation, from better data collection at the foundational level, better use and management of those data using AI and graph and other types of approaches, better analytics as well. And finally, we're talking about using federated approaches and really integrating some of these different methods into, I guess, the tricky real world of data governance, data sovereignty, and data policy. So I think we've kind of gone through the whole cycle. Maybe you got a few final thoughts about AI for public health. Should we be optimistic? Should we be pessimistic? Should we be somewhere in the middle, cautiously optimistic? What's your kind of final take for the beginning of 2026?
I think my final take is that anyone that tells you they know what's going to happen in AI is either already an AGI and can see into the future, or is just throwing darts, at the wall and hoping that they get lucky. So I think one thing that we can be sure of is that if we're not thoughtful now, building multi-sector coalitions that leverage the best practices that we already understand, like co-creation and thinking very carefully about the populations that we're serving, we know what will come out the other side, which are systems that are either not fit for purpose and gather dust on the shelf, or that exacerbate and generate new kinds of biases and inequities. And so what I would really encourage all of us to be doing is to think very actively and engage around how we build the trusted networks of collaborators that focus on local level challenges and building trust and creating software that functions for the individuals that we're trying to see benefit from them. And that will make us as AI, sort of future proof as possible, and ensure that whatever comes next, we're ready to use to improve the health and well-being of our global society.
Well, thanks so much, Sam. I think ending on the topic of trust between humans is very much at the core of public health. So that's a great place to end it. Thanks very much for taking your time to speak with me on the podcast today. And I look forward to hearing more from all of your interesting initiatives as we go forward.
Thanks so much for having me, Oliver. It was a real pleasure.
Thanks so much for joining us for this episode. We hope you enjoyed it as much as we enjoyed making it. Be sure to subscribe and share this podcast with your friends and colleagues. We'll see you next time.
The Innovation Forum AI podcast is produced by Zoila Leiva Rioja and brought to you by the WHO Hub for Pandemic and Epidemic Intelligence. We'd love to hear your feedback and ideas. Reach us at pandemichub@who.int.